I'm a abdominal radiologist. I'm a professor of radiology, and my areas of expertise are genitourinary radiology. Question is, for patients who cannot undergo an MRI, what else do we need to consider when we're going to do a CT scan for a patient with kidney cancer? So you've already heard me say I prefer MR. I've also mentioned there's some good points with CT. So a couple things I'd like to mention. One, we have to have good CT technique, and it has to be dedicated renal protocol technique, not the CT scan where you come to the emergency room with abdominal pain and they do just a portovenous phase scan. We're going to need pre-contrast studies and post-contrast studies at least 100-second delay. Both of those have to be the same slice thickness and a thin slice thickness, like a 3 mm slice thickness. We're going to have to be extra careful on interpreting our CT because we're not going to have 5 phases through arterial, early portovenous, late portovenous, nephrographic, and delayed, because all of those sequences or all those runs in a renal protocol CT, each additional run, it seriously accumulates the radiation dose. So we have to be judicious with the radiation that we do impart. So it's got to have good technique. We've got to look carefully at the collecting system. One of the most important things we need to do is, if we're evaluating an original renal mass, is we want to make sure it is a renal cell carcinoma. There are many other things that can occasionally be confused with renal cell carcinoma. I think it's important when we're evaluating a renal mass to describe the renal mass, its imaging characteristics, its enhancement pattern, and what we likely think it is. Then I think we also need to pause and run through in our mind all the possible options that would not require a partial or complete nephrectomy. Even if we do it silently in our mind, I do this on every patient I look at a renal mass. What types of things am I thinking of? A duplicated collecting system, which is sometimes confused with a cystic renal cell carcinoma. A column of Bertin, which is sometimes confused with a solid renal cell carcinoma. A renal infarct, pyelonephritis, a renal abscess, a renal artery aneurysm, which is more commonly seen now than years ago, because when patients undergo laparoscopic surgery and they clip a vessel, when they look through the laparoscope, they often hope that they have the clip on the entirety of the vessel. But sometimes it's only on 99% of the vessel, and a little aneurysm will form. Where years ago, when all patients had open nephrectomies, we didn't have intrarenal aneurysms. So again, enhancing masses is something we need to think about. Metastases to the kidney can sometimes have a different look. They tend to be more infiltrative. They're not as cortically based. Leukemia and lymphoma can have a range of appearances. And when a renal mass grows rapidly, it's unusual to be a renal cell carcinoma. Renal cell carcinomas tend to grow about 3 mm a year. So if we have a small renal mass and 6 months later, it's gone from 4 mm to 20, that's not a good look for a renal cell carcinoma. That's a better look for lymphoma. And then there's odd lesions. Patients that have autoimmune pancreatitis can have weird renal lesions that are inflammatory. So the first thing we need to make sure is, are we really dealing with the renal cell, or are we at least fairly confident we are? The next thing we want to do is really have a good quality CT report. That includes the size of the mass that we're talking about and its exact location in the kidney. We want to describe to the referring doctor, is the lesion exophytic, meaning it's sticking out of the kidney, it's endophytic, completely in the kidney, or what we call mesophytic, which is sort of a 50-50. We want to measure the distance from the renal mass to the collecting system. With all this information, we'll give the referring physician a nephrometry score. One can go online and just punch all this information in, whether the lesion crosses a polar plane, whether it crosses the renal sinus. its size, how endophytic or exophytic it is, its closeness to the collecting system, and we'll get a nephrometry score, which gives the surgeon information on how difficult this is going to be to take out. We're going to look for other lesions in the ipsilateral and the contralateral kidney. Lymph nodes, artery and venous, both anatomy and IVC anatomy, and looking for thrombus in the IVC or the renal vein. Then we have to take a close look at everything that could either preclude or delay workup or surgery. That includes enhancing masses in the liver, in the pancreas, bone lesions, and looking at the lung bases. I think that CT is good. We've been using CT for years in renal mass assessment and evaluation going forward. I think it's absolutely fine. I just think we have to have a good quality technique, and we have to be careful with the details of our report, and we need to look around for all different kinds of other information that could either preclude or delay the patient's definitive management of their renal mass.